Okay, why don't we go ahead and get started? Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. One of the things I love most about UCSF is teamwork and collaboration, and today is a wonderful example of teamwork and collaboration within our department and then across our department with the Department of Surgery. There are a few areas in medicine, certainly in cardiology, but even in all of medicine that I think have been changed as much in the last 20 years as our approach to valvular heart disease. My mother had a TAVR a couple of years ago, and 86, I believe, and it's pretty remarkable stuff that can be done both in imaging as well as non-invasive cardiology procedures, as well as changes in the nature of surgical approaches. And that is what we will talk about today with three of our experts in each of those domains. We'll hear three relatively short talks on it, and then we'll hopefully have some time for discussion at the end. Our three speakers are Kirsten Tolstrup, who's professor of medicine in our division of cardiology. She's also associate chief of cardiology for ambulatory operations, and she is an expert. She's a non-invasive cardiologist with expertise in non-invasive approaches to imaging generally, but particularly and relevant today for valvular heart disease. The second speaker will be Sami Elmira, who is chief of our interventional cardiology group at UCSF. We were thrilled to recruit him from Mass General 2 years ago, 3 years ago, so year and a half, that's all. Time flies. To lead this world-class program. He is an expert in approaches to valvular heart disease, and he'll talk about some of these new approaches, TAVR and MitraClip and others. And last but very much not least is Dr. Toby Duys, who is a heart surgeon and director of minimally invasive cardiac surgery at UCSF. He's done pioneering work in this area and has been a spectacular collaborator with our cardiologists and primary care docs and others who refer patients to him. And he has developed all sorts of new techniques for heart surgery and valvular surgery, including robot-assisted endoscopic surgery. So thrilled to have them here to discuss this rapidly evolving and a very exciting area of healthcare. And I think Kirsten is first.
Thank you very much, Bob. And it's so great to see so many people in person. And also thanks to everybody on Zoom to join today. It's a rather big topic, and we decided that we would try and focus on aortic stenosis, mitral regurgitation, and tricuspid regurgitation. So I got the task to go over the assessment of these valvular lesions, or patients with these valvular lesions, and I'll present the newest guidelines from 2020, and you'll see some of them are almost already outdated. During our talks, we will stress the importance of a multidisciplinary approach to these complex valve patients. So in general, when you have a patient with valvular disease, everybody must undergo a physical examination, 12-lead EKG, chest X-ray, and a transthoracic echo. But many also need a transesophageal echo, chest X, a CT scan, MRI, stress testing, maybe even hemodynamic cardiac catheterization. We also always assess the surgical risk, and that's where we calculate the STS score. And we look at comorbidity and frailment. In general, we state valvular disease in 4 stages, A, B, C, D. This is according to ACC/ASA guidelines. And typically, intervention is primarily performed on patients with severe valvular heart disease states C2 and D. So D is the ones with symptoms. That's why it's so important to ask for symptoms in these patients. C2 is the asymptomatic severe valvular disease that has some compromise of either LV or RV function. So the timing of intervention depends, again, as I mentioned, on presence and absence and symptoms. And really be clear, these symptoms can be very, very subtle. So you must be very specific in how you ask this. It is not uncommon that it is basically family that will say, Mom and Dad has started slowing down. You know, and they do the same things as they used to do, but much slower. And it's because they're protecting themselves really from eliciting symptoms. And again, TTE is absolutely paramount. It is no longer diagnostic cardiac catheterization as it was in the past. Transthoracic with all the bells and whistles in a good center can really diagnose this for the vast majority. We look for the response of the RV and the LV function. So just that you have severe disease does not mean anything needs to get done. But if the left ventricle or right ventricle feels this is a burden, so to speak, then it's time to intervene, or it's already maybe past time to intervene. And then we look for the effect on the pulmonary and systemic circulation. So pulmonary hypertension is often a trigger also. And then change in heart rhythm, such as development of atrial fibrillation. So according to the newer guidelines, every patient with severe valvular heart disease should be evaluated by a multidisciplinary valve team when intervention is considered. That is a class 1 indication, and is really one of the main reasons also that we are doing it here and that we are establishing a valve center of excellency with my esteemed colleagues that are here. And this talk here is really, it's a great opportunity for us to showcase actually what we do every day. We collaborate about patients pretty much on a daily basis. It's also considered reasonable to refer to Heart Valve Center of Excellence when you discuss treatment options for asymptomatic patients with severe valvular heart disease. So if they don't, whether the patient will benefit from repair versus valve replacement, patients with multiple comorbidities for whom valve intervention is considered. Another group that they don't talk about so much in the guidelines is those with multivalvular disease that were not a single lesion might meet the severe criteria. You can have patients with moderate lesions, or at least that's how we detect it. It looks like moderate. They might actually still benefit for intervention, and it's very complex to tease out which of the valves are actually significant and if they need multiple valves taken care of. So please send them to us. So as you know, aortic valve stenosis is the biggest one of these actually. And you know, this is something that typically affects the elderly presentation after the age of 65, but it's very prevalent, and Sammy will speak more to that, so that the severe aortic stenosis is seen in around almost 4% in patients of people aged 75 or older. The congenital bicuspid aortic valve is seen in 1 to 2%, and the symptoms occur typically 10 years before. Rheumatic aortic valve stenosis is not something we see terribly often. It's usually associated with mitral valve disease, and typically the mitral valve really drives the decision-making in the vast majority of these. So why is this important to get these patients? And Sammy will allude more to this. This is a slide from Bromwell from 1968, but that is really still stands. If the patient with severe aortic valve stenosis develop symptoms, they have a very poor prognosis. That is why it's so important that we see them and that we follow them closely. So what do we assess with echocardiography? Similar to what I mentioned before, we assess the morphology of the valve, the severity of the valve, the presence and the degree of aortic valve stenosis. We also look for other valvular lesions, because those lesions not only can affect how we treat, but it can also affect how we assess the degree. We can be quite wrong if there's concomitant other valve lesions. So just by transthoracic alone, and it will require more testing. Aortic regurg, mitral regurg, we look at LV systolic diastolic function, LVH and chamber size, and pulmonary hypertension. Aortic root assessment is very important, because that can be the determining factor if the patient gets referred for TAVR versus SAVR. The aortic stenosis intervention guidelines are somewhat complex, but you know, basically it shows that if you have symptomatic severe AS, it's a class 1 indication to go for intervention. And also if you are asymptomatic with LV dysfunction or dilation of the LV and so forth, it's also a class 1 indication. So then how do you decide if they need TAVR versus SAVR? That is also a very complex side. I'm not going to go over in detail, and Sammy and Toby will talk about it a little bit more. If you have a patient with severe aortic stenosis where you have found there's an indication to intervene and the life expectancy is more than 1 year, then if the patient is at prohibitive or high surgical risk, then it will be an indication to send for TAVR. Then if you have a patient with low to intermediate risk for surgery, then we look at the age here. And if the patient is below age of 65, class 1 for SAVR. If they're above the age of 80, then it's a class 1 for TAVR. And then we have that gray zone in here between 65 and 80, where they could go either way. So that's where the workup is really critical. It's really critical to know if they're good candidates for TAVR. Do they have good access site? Do they have a particular high risk for pacemaker implantation, or for surgery? If they have a markedly dilated aorta, then SAVR would be more important to send them for, so they can get complete sort of fixing of all their lesions. So again, this is the reason why we need the interventional cardiologists, the non-invasive cardiologists, the imager, and the CT surgeons when we discuss these patients. So in summary, for aortic valve stenosis, there's no medical treatment for aortic stenosis. Patients with severe asymptomatic AS should be followed closely by a valve specialist. Typically, I see my patients every 6 months unless they're very reliable in reporting symptoms, and then an echo every 6 months. If in doubt, you can consider stress echocardiography. Remember, symptomatic aortic stenosis is contraindicated to perform stress testing, but in the asymptomatic, it's actually safe to do. So refer to a valve center, to a valve expert. Patients with symptoms should be referred for evaluation of candidacy for intervention immediately. Do not hesitate. They need to get seen within a couple of weeks. Age itself is not a contraindication for TAVR versus SAVR, so don't think you see this 85-year-old and think that there's nothing we can do. Maybe there is. TAVR is also now approved for low to prohibitive risk severe aortic stenosis, and has been for the last couple of years, actually. So mitral valve regurgitation, I want to focus on a couple of key things that I'm not sure everybody is so clear on. We talk about primary MR and secondary MR. And the primary MR are the cases where the mitral valve is diseased. That means if we intervene on the mitral valve, it's curative. The secondary MR has structurally a normal mitral valve, and the left ventricle is diseased, or maybe there's left atrial enlargement that can also cause leak. So mitral valve repair or replacement may occur, but it's not curative. So the guidelines for these are very, very different. So again, what do we look at? We for transthoracic or with echo, we assess the LV size, volume, and function. And if there's LV dilatation, it's more likely to be severe or chronic MR. If the left atrium is big, it suggests chronic severe MR. We look at the whole mitral valve apparatus. We look at the left ventricle wall, papillary muscle, chordae, annulus, and valve. And again, that is to see if we can figure out if this is primary or secondary, because the treatments are so vastly different for the two. We also look at the mobility of the valve, and if we see a flail leaflet and chordae rupture, then most likely there's significant mitral regurgitation, even if we can't quite see it by color. We, of course, grade DMR, and like every other valve lesion, we rarely intervene with anything less than severe mitral regurgitation. Moderate to severe is also indication to intervene with if other criteria are present. TEE is almost always done on mitral regurgitation. We do it to assess for repairability and also for the type of repair that can be done, and then also sometimes to confirm the severity. And these are done really in the hands of very experienced echocardiographers. So it's not everybody that can do these kind of protocolized TEEs. So the medical treatment for mitral regurgitation for primary MR, there are no class 1 indication for mitral treatment. The treatment is intervention. I also want to point out that to treat a chronic severe mitral regurgitation patient with vasodilators in the absence of a hypertension is actually class 3, and you can do more harm than good. This is something that certainly was done many years ago when I started out in my training, so it is not advocated that you do that. However, for secondary MR, the first line treatment is GDMT. So you really need to treat the heart failure, you need to treat the ventricle, you need to treat the atrial fibrillation, you need to treat the volume overload. And only when all that is treated, or you can't treat them more and they still have symptoms and meet certain criteria, may we actually intervene. So this also takes a multidisciplinary team, including what I spoke about, but also a heart failure specialist. So heart failure is an integral component also of our comprehensive valve center. So what is the indication for intervention in severe primary AMR? It is similar to other conditions that if you have symptoms, then you really intervene. Or if you are asymptomatic and the left ventricle dilates or you have a low ejection fraction. For primary AMR, surgery is first line of treatment. And mitral valve repair is preferred, and patients should be referred to centers performing repairs. If we are lucky here, we have excellent surgeon here that can do these repairs from a minimally invasive approach typically, so they avoid a median sternotomy. If you end up in a center where they cannot offer repairs, then you really should refer your patients out. It would be a disgrace to send them for a median sternotomy and replacement if you actually could repair the valve. So MTEER is really at this moment only for high risk or prohibitive risk patients with severe primary AMR, and it's a class 2A. Ongoing trials, and Sammy will speak more about that, and that landscape will also change. So indication for intervention in severe secondary AMR, as I mentioned before, GDMT is first-line therapy, but if you need to intervene, then MTEER is actually preferred over surgery, and that is a class 2A indication. And if you send the patient for surgery, maybe it is someone that is not a candidate for the repair by TEER, or somebody that is undergoing maybe CABG and need the valve fixed, then in general it's felt that probably mitral valve replacement is better than repair because the repairs may not last so long. But Toby might address that also later in the talk. So in summary, for mitral regurgitation, refer to a valve center and valve expert. And there's a great variety of causes. And those with primary valve disorder, there's clear guidelines of when to replace or repair the valve. It's much harder for the secondary functional AMR, much harder to treat, much harder to assess, and definitely somebody that we would like to see, and really that we work together on trying to tease out what is it we should offer these patients. MTEER is preferred for secondary MR after optimal GDMT. We like to see them have optimal GDMT for at least 3 months. And when we study them, we need to have them euvolemic or near euvolemic. You'll be amazed how many times we have somebody with severe mitral regurgitation, volume overload after the diuresis, they have mild moderate mitral regurgitation. So again, as I mentioned, trials are ongoing, and this landscape is for sure to change very soon. Tricuspid regurgitation, very briefly, has been the forgotten valve for many, many years. It's not so forgotten anymore. About 80% of severe TR are functional, most often due to left heart disease, atrial fibrillation, maybe pulmonary hypertension, RV dysfunction, RV dilation, and so forth. So this is an example of the difference between primary and secondary TR. You have here a patient with tricuspid valve prolapse of the anterior leaflet or posterior leaflet here, sorry, and there is basically severe tricuspid regurgitation that goes towards away from the prolapse leaflet. This one here is somebody with left heart disease and mechanical mitral valve. There's right atrial dilation, RV dilation, and annular dilation. So the septal leaflet gets a little tethered, and there's severe tricuspid regurgitation due to this. Again, two very different ways to address these leaflets here. So why is this important? Well, the outcomes of patients with severe tricuspid regurgitation is not very good. And actually in severe TR untreated, less than 50% will be alive at 10 years. So when we assess and grade the tricuspid regurgitation, it's actually kind of hard. It is a harder valve to sort of be quantitatively accurate and so forth, but we try to identify the causes of the tricuspid regurgitation, the severity, chamber sizes and function, like we do with all the other valve. And then the presence or absence of pulmonary hypertension becomes really, really important. Also because there could be some exclusion criteria if there's too much pulmonary hypertension. We look at IVC hemodynamics just as for mitral regurgitation. These patients really need to be euvolemic or near euvolemic when we study them for us to understand what's truly going on. For many of these, we perform a transesophageal echocardiogram, and that is for the detailed morphology and for repairability, and also to look much better at the right ventricle. And then particularly with the new percutaneous procedures we can perform on these, then we do CT scans, and that adds additional information about anatomy and the chances for repair. So the main medical therapy for tricuspid regurgitation is diuresis. That's really all it is, but that's really also what you need to do. When do we intervene for severe tricuspid regurgitation? I think it's changing. I think we are learning that we need to get to these patients sooner than later. So before the right ventricle gets too dilated, before the right ventricle gets too dysfunctional, or maybe even dysfunctional at all. We are not quite sure about that. And we also want to, of course, avoid end-stage organ disease. You will be surprised how many times we have patients referred for liver cirrhosis that actually have liver cirrhosis due to tricuspid regurgitation. It certainly happens at least a few times every year that we see that. There's a huge interest in transcatheter procedure. And within the last, is it within a month, 6 weeks? We got TriClip and Evoque FDA approved. So my slides are already pretty old, and I had to revise this just for this talk here. So again, the indications for intervention in severe TR, the 2020 guidelines are old, but this is what they show. There was only one class 1 indication for tricuspid valve intervention, and that is if the patient was undergoing left-sided valve disease surgery. That is for sure to change. So in summary, for the tricuspid regurgitation, it's very prevalent, and it confers a poor prognosis with 10-year mortality greater than 50% if severe. One must be accurate and have quantitative assessments of the degree of TR when the patient is optimally treated. TR should be addressed before RV failure ensues, so that means please refer them to us early. And multimodality imaging is often needed to determine the optimal intervention. And again, like the other ones, but definitely so with the tricuspid valve, these are very complex patients, and we need to see them together. So we have always non-invasive cardiology, imaging specialists, structural interventionalists, and CT surgeons, and often heart failure are involved in these cases. Thank you. That's all I have, and I'll hand it over to Sammy, and be ready for questions later. This is
Thank you so much. It's a pleasure to have the opportunity to speak to you all. There is a rapid evolution, as Kirsten has nicely outlined, within this space. And so I'll do my best to try to give a little bit of historical perspective and really introduce some of the next steps in the transcatheter valve space. So first of all, Kirsten did highlight the mortality risk associated with severe symptomatic aortic stenosis when not treated, right? So the Braunwald curve with the survival dropping off a cliff. I want to just put that in context and demonstrate here the 5-year survival, which is only 3% if severe aortic stenosis, symptomatic aortic stenosis is not treated. And that is much worse than the leading causes of cancer mortality. So again, to highlight her point, very important that these patients get treated in a timely fashion before they succumb to their disease. Now, back in 2001, despite that horrible mortality rate, about 30% of patients were not being treated. And that was because at the time, surgical aortic valve replacement was the only option. And many of these patients were too old or too sick to undergo surgical intervention. And it was on that background that TAVR was introduced. And so we started off with the PARTNER 1B study that you see there in the corner. These are patients that were too sick for cardiac surgery. They were randomly assigned to either get TAVR or really medical therapy, which is not much. This is a study, of course, that demonstrated that TAVR is a life-saving therapy compared to if there's no other treatment option. Then we looked at PARTNER 1A, high-risk patients that could undergo surgery, but of course at increased risk. Another New England Journal publication, and showed that in high-risk patients, TAVR was as effective as surgery in prolonging life out to 2 years, and this has been extended since out to 5 years. With that success and the excitement about the technology, we then shifted to even healthier patients, intermediate risk patients in the PARTNER 2 study. A large randomized clinical trial, 2,000 patients comparing surgery and TAVR head-to-head, and again, nearly overlapping event curves here with a composite endpoint of mortality and stroke. And finally, again, with that excitement, we shifted even healthier patients, low-risk patients, 1,000 patients randomized against surgery, And again, actually with a broadened primary endpoint, essentially an advantage to TAVR over SAVR. But keep in mind, as Kirsten mentioned, these are all patients over the age of 65. And these results have panned out to 5 years. Here's the results of the PARTNER 3 study, low-risk patients randomized head-to-head. You see that the all-cause mortality curve is largely overlapping out to 5 years. And also that valve hemodynamics continue to be quite favorable, with no clear difference between TAVR or with surgical intervention out to 5 years. And this study is going to continue following patients to 10 years. So hopefully we'll have clear guidance in terms of valve durability or comparable valve durability of the two technologies. So with that, of course, TAVR gained a presence in the guidelines, as Dr. Tolstrup has highlighted, where in patients over the age of 80, it is the preferred strategy for treating aortic stenosis. In patients under 65, surgery remains the preferred strategy. And of course, patients 65 to 80, that gray zone where either therapy is anatomically suitable, the decision should be made with a shared decision-making approach with the physicians, the heart team, and also, of course, the patients, informing them of the risks, the benefits, the uncertainties about valve durability, and then really making a joint decision with our patients. So with that success, of course, we now have broadened indication for TAVR, and the number of aortic valve replacements happening in the United States, inclusive of both surgery and transcatheter, has over doubled. And that, of course, is a tremendous success, and we have gotten a lot better at doing this procedure. So now we have in-hospital mortality rates that are under 1%. Patients go home the next day. The stroke rate is under 2%. Conversion to surgery is on the order of what we see with PCI, around 0.3%. And the pacemaker rate now is comparable to what we see with open heart surgery. So with that, the question is, well, what comes next? We've been successful so far in those patients, low to high risk over the age of 65. So now what? Well, so first of all, we're looking at expanding the indication. So given the lack of specificity and the lack of sensitivity frequently of clinical symptoms in our older patients that may not be that physically active, there's a tremendous amount of attention to whether we should be treating asymptomatic severe aortic stenosis. Here I'm showing the study design for a clinical trial that will be reported later this year, randomizing patients to receive early transfemoral TAVR or the standard of care, which is watchful waiting until symptoms develop. And these are rigorously assessed patients with stress testing to confirm that they truly do not have symptoms. The other area of interest is, what about moderate aortic stenosis? There are patients such as those with a reduced ejection fraction or those with heart failure with preserved ejection fraction that have demonstrated cardiac symptoms in the setting of in the setting of moderate aortic stenosis. And so the question becomes, does alleviating that afterload with TAVR, given that it is now a lower risk procedure, going to result in alleviation of those symptoms? The TAVR Unload study is looking specifically at patients with heart failure with reduced EF. The Progress trial, which is finished enrolling and we're in the follow-up phase, and UCSF was a site in, hopefully we'll have results within the next 2 years. But perhaps bigger than all of this is the fact that we are, despite the advent of TAVR and the expansion of TAVR, not doing a great job treating all of our patients. This is a study that I published using the Mass General Brigham system, spanning nearly 18 years of experience. And we found that despite the introduction of TAVR, our treatment rates were no better than they were in 2001 before TAVR. And that overall, we were treating about 50% of patients. And of course, this unfortunately corresponded to poor survival. You see the very clear separation of these survival curves, regardless of what type of aortic stenosis we're talking about. So beyond just improving TAVR and expanding TAVR, we have to do a better job at identifying these patients, getting them to therapy, having heart valve teams evaluate them, and then treating them in a timely fashion. And that is, in fact, what this study triggered. So the American Heart Association has launched the Target AS initiative. Again, UCSF is a center within this program that has the goal of improving quality of aortic stenosis care across the country. And that includes not only getting people to treatment, but it is also going to hold every member of an institution essentially hold their feet to the fire to see how quickly after a patient gets an echo, do we have them evaluated if that echo revealed severe aortic stenosis. We also have to ensure that echo labs across the country are appropriately reporting the quantitative metrics that are needed to grade the severity of aortic stenosis, and that the echo report actually specifically states this is severe aortic stenosis, which you'd be surprised frequently does not happen at many labs across the country. Here's a list of some of the centers that have initially adopted this, and the American Heart Association has received approval to expand to 80 sites nationally. And again, that is a large initiative that has their full support at this point. In terms of mitral valve disease, shifting gears a bit, Dr. Tolstrup has already mentioned a lot of this. I'm highlighting all of the ongoing different types of transcatheter therapies, although the greatest experience is with edge-to-edge repair, mostly with the MitraClip, although the Edwards-Pascal system has been introduced recently. There are ongoing investigations to try to percutaneously perform an annuloplasty, and of course also to percutaneously replace valves, in addition to what I'm showing here with replacement or with repair. The initial experience with edge-to-edge repair was reported in the Everest 2 study. I'm showing here the 5-year results of that study. We didn't do a great job with this. So about 20 to 30% of patients, despite going edge-to-edge repair, had significant residual mitral regurgitation. This study showed that the approach was safe and that it did improve quality of life and it did no harm, but there was a substantial proportion of patients that did not reap a significant benefit, at least not to the extent that you get with surgical repair. And so because of that, the approval by the FDA and in our guidelines is that repair is a backup to surgery and is only considered if a patient with primary mitral regurgitation has high risk for surgery or extreme risk for surgery. I will say, however, now we are on the 4th generation MitraClip device, and we have just simply gotten better and we understand the mitral anatomy to a much greater extent than we did back then. And so you see here that now we have rates of residual, moderate, or severe mitral regurgitation with edge-to-edge repair of less than 2%. And this is comparable to what we frequently see with surgery. We also have newer devices that similarly are resulting in a marked reduction in MR that seems to be durable and seems to be almost uniformly attainable. And so with that, there is now an ongoing study, the REPAIR-MR trial, that is looking at intermediate risk patients, defined as anyone based on an STS score greater than or equal to 2, or age 75 or greater. And this is a head-to-head randomized study looking at edge-to-edge repair versus surgical mitral valve repair. And we'll have to see. But I think there's a lot of excitement and sense that perhaps edge-to-edge repair can be expanded. Dr. Tolstrup did also mention secondary mitral regurgitation. I just want to show again the COAPT study on which the trial on which the recommendations she highlighted are based. This is a randomized trial comparing mitral edge-to-edge repair to goal-directed medical therapy alone. But all patients were initially fully maximized on goal-directed medical therapy, and only if the symptoms persisted and only if the MR remained severe were they then randomized to undergo therapy or not. And with those highly selected patients, these are the results with very robust separation of the survival curves in patients that were treated versus those that were not. And every single secondary endpoint was strongly positive in favor of edge-to-edge repair. But again, only if goal-directed medical therapy fails. That's a very important piece. And I do have all of these patients evaluated by heart failure members of our team to help get to maximal goal-directed medical therapy. And with that, this is now the preferred strategy for secondary mitral regurgitation over surgical alternatives. Finally, with tricuspid regurgitation, in the last minute or two, again, highly prevalent, 1.6 million cases in the United States, but yet very small fraction of these actually get surgical intervention. This is mostly because surgical intervention on tricuspid valve disease is at best intermediate to high risk. These patients are sick and they don't do well with open heart surgery. The rate of 30-day mortality in the US across the country is 7.3% on average. This is at least twofold higher than aortic and mitral valve surgery, if not more. So the TRILUMINATE study was recently published. This is a randomized clinical trial looking at TriClip, which of course just received FDA approval. It found, at least at the 1-year time point, that there's an improvement in quality of life. There was not actually an improvement in mortality or heart failure hospitalization at 1 year. There's some hypotheses that maybe it will take longer for the curves to separate. But based on this, the FDA did approve this technology, and we are in the process of getting it. The Pascal system, very similar, also being evaluated as a comparable device. But something I'm very excited about, and we do have here, is the EVOQUE transcatheter valve replacement device that was tested in the TRISCEND and TRISCEND II study that essentially obliterates the tricuspid regurgitation. You go down to trivial or mild at most. And this did receive FDA approval just within the last couple of weeks. And actually, UCSF is the first UC in the UC system to do a commercial tricuspid valve replacement, and one of the first in the country with the new FDA approved commercial device. It does improve quality of life based on the initial time point, and there does seem to be some separation of the curves in the data submitted, of the survival curves in the data submitted to the FDA, but we're waiting on the publication of the 1-year time point. And just quickly, in a minute, I'll show just one patient who had a 75-year-old heart failure with recovered EF, had wide open TR. You see the leaflets are nowhere close to each other with a coaptation gap of about 1.5 centimeters, and who was receiving Bumex 3 milligrams BID. So very challenging patient to manage. We ended up doing an EVOQUE case. This was a study case before the FDA approval. This valve is deployed in a very slow and controlled fashion over an hour to 2, and very well tolerated. And despite concerns about how the RV is going to tolerate these sorts of things, they actually do quite well. This patient was discharged with a mean gradient of 4 with trivial tricuspid regurgitation and completely came off of diuretics by their 1-year follow-up. So really a pretty remarkable result. So we're hoping that the clinical impact of this intervention will be much more robust than what we've seen with others. With that, I will stop and pass it over to Dr. Doisy.
Thank you very much. It's an honor to be here and be talking about valve surgery. And valve surgery in 2024 is mainly minimal invasive. So I would like to give you a glimpse in what we're doing. Just barely looking at the numbers, when we start with the mitral valve, we do 2 times to 3 times more mitral valve repairs than we do replacements, and that's because the most degenerative valves can be repaired these days, as Kirsten was alluding to, and the replacements are mainly rheumatic disease with stenosis. On the right side, you can see our standard setup for a mini mitral case, and it means that we have an incision which is 1.5 to 2 inches max on the right side of the chest. So to repair these valves, we use an operative technique which is referred to as the RESPECT approach. And that means that ruptured chordae we will replace. So we have these Gore-Tex neochordae, which we anchor in the papillary muscles, and then we reattach to the leaflets. So we don't have to resect prolapsing valve tissue because we believe valve tissue is very precious. We want to preserve it. We want to work with it. And that's why we have moved from the resect to more the respect approach. At the end, most patients get an annuloplasty ring to lock in the repair that we have so that over time there's no additional dilatation and recurrence of MR. I'm going to show you a few pictures, a few cases, because we can really treat all different morphologies of degenerative mitral valve regurg with these mini mitral approaches. And a few years ago, David Adams' group, they came up with a classification to talk about mitral valves and to classify them into buckets based on the complexity of repair. And if we look at this case, this is an isolated P2 prolapse, which is classified as a simple to repair case. And you see here, this is the surgeon's view. You see, this is the P2 segment, which I'm pulling up here with this long pickups. You see it's increased in height, but it's not terrible. So we expose the papillar muscles, anchor our neochordae, and then we anchor them to the leaflets, adjust the height, and at the end have a nice repair. So we can also do these repairs in intermediate complexity cases, and those are cases involving the anterior leaflet. And you can see here, this is an A2 prolapse with a ruptured cord here. Again, we anchor these chordae on the anterior leaflet and adjust the length. This is a case A2 and A3 prolapse, so pretty big prolapse, so we need more chordae to fix this valve. A case where the complete posterior segment has been prolapsing, and we put in several chordae to pull down the different scallops of the PML. This is a pretty complex valve. It's what we call a Barlow's valve, where you see that all the segments are really involved in the disease process. You see myxomatous tissue, and you see tissue redundancy. And despite me talking about respecting the tissue, if you just have a lot too much tissue, we have to get rid of some tissue. So we have smooth coaptation surfaces, and these are really the cases when we still do resection of the tissue just to make the valve look more smoothly. In cases where the valves cannot be repaired because of severe endocarditis, showing here, or status post MitraClip, where there's lots of fibrosis, and this poor guy was on top, had endocarditis after his MitraClip. So these cases we treat with valve replacement, and the same approach, it's the same incision. We use the same mini mitral incisions for cases where it's really a combined team approach that Sammy and I would do together in specific cases where we believe the transcatheter technology needs to combine with surgery. And there's one case that I want to present. This was a redo case, mid-80-year-old patient, porcelain aorta and severe MAC. And this is the valve, severely calcified, tiny little opening. And what we did is we go in, like in a mini mitral, we resect the anterior leaflet, which is really mostly calcifications in a case that's as bad as this one, just to get rid of the calcium that could be protruding into the outflow tract. And then we go in and place the new valve. You see a lot of hardware. This is our retractor, the echo probe. You see some sternal wires from prior surgery. And we go in and position the TAVR valve. And you see this is an S3 here. And we've become pretty good at assessing just visually where the valve has to sit. And then we deploy it in place. And what we do is we throw in stitches afterwards, so the valve is really secure. So we've resected the anterior leaflet and sewed it in. So we feel it's a pretty good combination of both what we can do surgically and using transcatheter technology. You see the valve in place. It's pretty amazing. I think how much space these balloon expandable valves create in a very highly calcified environment. Quickly talking about the aortic valve. To do a minimally invasive aortic valve replacement, we would move the incision a little bit more medially, go in there. It's a pretty straight view onto the valve. This was a young patient with a bicuspid aortic valve. We would still do pretty standard surgical replacement here. You can see the tissue valve in place and with a nice post-op echo. So to access the tricuspid valve, we use the same incision, the same access that we use for the mini mitrals. And as Kirsten alluded to, we see a lot of mitral valve patients that also have tricuspid valve disease, but we also treat isolated tricuspid valve in select patients that have gone through the heart failure team. And isolated tricuspid cases can be done beating heart. And this is just an example on the left side of a tricuspid valve, which was just severely dilated. And we repaired it by implanting this tricuspid annuloplasty ring. On the right side, you see a tricuspid valve replacement. We do this for patients with isolated valve disease, but we also do this as an add-on for mini mitral patients. So thank you very much for your attention. I think we're happy to take a few questions. Thank you very much.
That was superb. And Toby, what you call simple, like that does not look simple to me. Let me start with a few, then we'll open it up. The fact that the indication for surgical approach in people under 65, I guess I never heard the T crossed about why that is. I assume because of the longevity of TAVR, or that we don't know yet about what the longevity in someone who's got 20 years of life expectancy. What's going on for a 60-year-old today? Is that on, Sammy? Let me just.
So there we go. Yes, I think you're absolutely right. It's because of the durability of these valves and the options for valve and valve intervention, or TAV and TAV intervention. So essentially, it's 65 or a life expectancy less than 20 years is the indication for TAVR. So certainly if you have a younger patient who has end-stage renal or cirrhosis or some other comorbidity that reduces their anticipated survival, then they may be a candidate for TAVR. But the concern, and I think what is entering our thought process at this point, especially for younger patients, younger meaning 65 to 70, is that we're thinking about when we look at a CT, if I do a TAVR now, will I be able to do another one in 10 to 15 years? And so depending on the sinus depth, depending on the coronaries and where they are relative to the annulus, depending on the sinotubular junction, the height, its width, all of those things we can begin to predict whether the patient will be amenable to a second transcatheter procedure. If they're not, I think we do need to, in that situation, have surgery be the first intervention, and then do TAVR in the bioprosthetic surgical valve, and then potentially even a second TAVR. But that gives a younger patient a much longer approach. There's been discussion about surgery first.
Yeah.
But in general, I'm sorry, there's been discussion of
TAVR
TAVR, then
first.
surgery, then TAVR. So far, the data suggests that surgery to explant a transcatheter valve is higher risk. And so that's something that we're trying to avoid.
And Toby, I guess the parallel issue is how long does a surgical, it sounds like you're only using tissue valves these days. There's no more mechanical stuff.
So that's a good point that I wanted to make and bring in here. So historically, the cell for a mechanical valve, which most people don't like because of the anticoagulation, is the longevity. And historically, if you have a bioprosthetic valve and it fails, the patient had to come back for redo surgery. And that obviously has changed because they get multiple lifespans of valves out of one surgical procedure. So even the discussion between having a tissue valve or a mechanical valve is now heavily tilted towards tissue valves, because patients come in, we put a good sized surgical valve in the first time, then they can come back if this valve is worn out, and they get a TAVR, and it's a pretty straightforward procedure. You know, it's the perfect landing zone for any TAVR. It lights up on the fluoroscopy. It's perfectly round shape. You know, and even they might be candidates for, you know, an additional TAVR down the road we will see. So I think the TAVR technology has really reshaped how we think about mechanical.
And what's the
versus-
life expectancy of the tissue valve these days?
I mean, we still hope, it's 10, 15 years, could be long. It's very heavily dependent on the age of the patients. In young patients, they get worn out much, much quicker.
Huh.
They last longer in older patients.
Why is that?
Why is that? So we believe that, they're metabolically much more active. There might be some immune component that plays into this. It is very, very obvious to see. So our threshold for putting mechanical valves in is now really very young patients who just, happen to need a valve at a very young age, because we can't, do this TAVR like over and over again, every couple of years. But at least over 50, I think I haven't put in a mechanical valve in anybody 50 plus in a very long time.
Interesting. Kirsten, go ahead.
I was just going to say we're a little bit. You didn't hear a solid number in terms of valve durability, and I think part of the challenge is there's not really been any long-term studies that have systematically and in a protocolized fashion followed up on these valves.
Right.
Not all valves are created equal, so there are certainly some valves that we're seeing with high degree of frequency that are failing after 7 years, surgical valves. There are others that have a much greater track record that are lasting 15 to 20 years. And I think that's what most surgeons are using now. With TAVR, we just don't know, because the initial TAVR valves outlasted the patients in those studies. We're conservatively telling patients 10 years, but the study I showed that's going to have 10-year follow-up with annual echoes is really going to be the first study of its sort to really show long-term durability of these valves in a structured fashion.
And you made the point that 65 to 75 is patient decides, shared decision-making. What do you find in your experience when you lay out the odds and the idea that whatever we're doing might fail over a period of time, and it blends into life expectancy and all of that?
I think you've actually highlighted it nicely. It's interesting, because a lot of us say, you're going to offer them something that's minimally invasive. Why in the world would they not take it? But that's actually not true. There are patients that assign different value to different elements. So I've had patients that say, no, we're going to have surgery, when I really talk to them about the uncertainties of long-term durability. And they have said, you know what, I'll take surgery since we think it's going to last longer. And there are other patients that say, listen, I want to live my life now. I don't want to recover from surgery. So give me the TAVR now, and whatever happens down the line, I'll deal with it. So it really is dependent on that patient's values and goals for their life.
Yeah, interesting. I would have expected that most people would say TAVR. That's interesting in your experience. Kirsten, nobody mentioned coronary artery disease in terms of the workup. Do people get caths anymore? Or we feel confident enough when we identify valve disease that they don't need a cath?
Yeah, it depends. So many of these patients, so sometimes for the TAVRs we do, because to place a TAVR valve, they get rapid pacing for about 30 seconds. So essentially have cardiac standstill and no cardiac output. And if they have significant coronary disease, they will not tolerate that very well. But every TAVR patient will get a CT scan. So if they have no angina, at least, then sometimes we look at how much coronary calcification they have and what it is. Sometimes they get an angiogram on the table, and sometimes we do it in a staged fashion where we truly want to make sure we exclude coronary disease. So it's on a case to case. For mitral TEER and tricuspid TEER, we don't really typically necessarily work them up unless there's some indication that they have coronary disease, but they don't need an angiogram.
And when they have coronary disease and valve disease, does that change whether it's a surgical or a non-invasive, less invasive approach?
Absolutely can change it. Yeah. So this is, again, one of the reasons also we actually have a multidisciplinary revascularization conference. So sometimes we decide for hybrid, or sometimes that would then favor that they truly go in to the surgeon instead of getting one percutaneous therapy and another, that we can't fix percutaneously.
So if you're going to do it percutaneously, you'd stent first and then later bring them back for.
Yep. Sometimes there's a stent first and then a percutaneous valve, or sometimes they go in for full mitral valve replacement as well as CABG, so or aortic valve. So it is, again, I think one of the reasons why it is so important. There's not one single person of us that can have all this information and understand all this that we do. We meet every Monday morning at 7 a.m. and discuss these patients in detail. And also, I just want to say about especially the aortic stenosis, but really also the mitral as it becomes more common, really be careful about just telling your patients, yeah, you can get a TAVR and we can put it in by catheter-based. It is so difficult to walk away from that if they already have been introduced to that. It would be best to let the heart valve team have that discussion with the patient, because the nuances are so difficult and so complex. It's even for us that do it every day, it's really, there's a lot to keep track of.
Yeah. Anybody want to add anything, Toby?
So when we, usually we've been pretty conservative in surgery. We've wanted to see a cath. Since our minimally invasive patients get a CT scan, I think we have the same approach. If they just have no calcium in their coronaries, I think we're fine, especially when they're younger. So, but how do we deal with a patient who is scheduled for a mini mitral and then, you know, he does get a cath and there's a stenosis? Does this necessarily mean he gets a CABG and he gets a sternotomy? And it usually doesn't. So we really look at what's the lesion. And I think what's pretty clear, if it's a prox LAD lesion, we would still recommend, you know, a sternotomy and getting a lima to the LAD and then getting the mitral valve fixed. If it's a less important branch, I think we've moved to still doing the mini mitral and then the patient getting a stent later, because the issue is also, why do we do mini mitrals instead of sternotomies? And the reason is really that when we compare it to mainly historic controls, because we do so few opens anymore, is mini mitral is really a very safe, if not the safer approach. It reduces like the post-op AFib and patients get rehabilitated more quickly. So there's a clear advantage of doing this. And we would only switch to sternotomy and combining it with CABG if it's really a prox LAD or something very relevant.
Makes sense. Let's open it up to other folks. Yeah, say who you are.
I'm Tyler, talking my grad student, dot physician. This is mildly redundant to Bob's first question, maybe, but considering the need to try and preempt symptom development with longevity of implants, I'm wondering for congenital patients specifically, where hopefully you're able to for some kind of intervention, how do you balance how early you go for a valve replacement with not wanting it to.
So a young person with congenital valve disease, and how do you balance that? You might have 30 or 40, 50 years we're talking about.
So if you have a small person and congenital disease, it's not only the longevity of the valve that would demand some reoperation, it's also the baby, the kid growing and just outgrowing the valve. So that's something, it's hard to win. So they need several surgeries, usually just necessarily because of that. And so the valve type is also just factoring in, you know, how long will this last and when do we have to operate again?
I'd say,
I'm sorry, go ahead, Sammy.
I would just say that's an interesting cohort, because we're being asked to consider transcatheter valve therapies in many of those patients because they've had 4 or 5 prior surgeries. A lot of times the endpoint for those patients is heart transplantation. And so offering a transcatheter therapy as a bridge, let's say to give them another 10, 15, 20 years before they actually have to have a heart transplant, is being considered more and more, but clearly outside of the guidelines and not something that's been studied in any standardized fashion.
Lakshmi, you have one from online?
One from the audience is about what happens to left atrial function and AFib risk after all these procedures, and does the risk differ?
So with TAVR, the incidence of periprocedural AFib is exceedingly small. And so that is something that I think has been found to be less than with open surgery, because the stressors on a patient's body and the inflammatory process and everything else that triggers postoperative AFib is less relevant in the TAVR space. I don't there's very poor data with transcatheter mitral intervention. Certainly, if one of the pitfalls of mitral interventions on the transcatheter side is inducing mitral stenosis. So if somebody has a small mitral valve area and you deploy and leave that MitraClip in place and actually have a higher gradient, presumably those patients may be at increased risk of developing AFib, but it is, again, very poorly reported because normally we don't leave those devices in place if we induce mitral stenosis. They actually can be removed before they're fully released and deployed, and we can, of course, assess them with our echo colleagues before doing that. On the tricuspid side, we don't know. The one thing that I will say, however, is that what we're learning is just the interplay between atrial fibrillation and tricuspid valve disease. And the trials that I mentioned, both in TRILUMINATE and TRISCEND, 90% of the patients had AFib. And so it's very clear that AFib actually causes some degree of annular remodeling and dilatation that likely is contributing to the presence of the tricuspid regurgitation in the first place. And there are a few studies in the EP world looking at rhythm control as a potential strategy to help improve or lessen the burden of TR.
And just surgically, we have a lot of mitral valve patients coming in, obviously with AFib. And if we do the mitral repair, then we just add the Mays procedure and we close the appendage routinely in these patients.
And that cures the AFib?
Well, it reduces the risk of AFib since the appendage is closed, and depending on how long the AFib has been present, we actually get some patients back into sinus with the Mays procedure during the case. So that's obviously helpful.
I mean, does anybody, that's maybe a naive question, as we think about the cure rates for AFib ablation, do people do a version of that when they're in there, either transcatheter or surgical for the patient with AFib?
More so with surgery, I believe, with the Mays procedure.
Oh, in surgery, we do this very routinely. We usually use the cryoprobes, which are very easily applied just to the atrial tissue. And again, if it hasn't been around for too long, then there's a pretty good chance that we can still get the patient back into sinus.
Right. Maybe my last question, didn't really talk about, you talked, Toby, about that if you have tissue valve, it obviates the need for anticoagulation. Is anticoagulation, and we'll assume people who have AFib need it, but for everybody else, is that a differentiator in terms of decision-making about a transcatheter approach versus surgery, or they both imply the same approach to anticoagulation?
I think mostly the same. So with TAVR, you don't need anticoagulation. There's some practices where you put patients on dual antiplatelet therapy, so Plavix for 6 months, and then lifelong baby aspirin. I will say the data behind that recommendation is very poor. And so we've moved away from that to some extent and just keep a lot of these patients on aspirin alone. Similar recommendations with mitral edge-to-edge repair. The one area is with replacement. These are technologies that are just being developed for mitral replacement. I will say there is anticipated to need, even though we don't have FDA approval yet, there's anticipated to be a need for anticoagulation for patients that have mitral replacements for 3 to 6 months. Similarly, on the tricuspid side, for repair, an aspirin is fine, but for replacement, 6 months of anticoagulation is warranted.
Is your replacement tissue or it's mechanical?
It is tissue. It's tissue within a metal frame of some sort, usually nitinol.
Right. And Toby, it looked like your repair still involved that meshwork thing.
It does. So we pretty much put an annuloplasty ring in every patient after successful repair, and we put patients on aspirin Plavix for 6 months, and then it's only baby aspirin. Again, I think that the data isn't very strong, but we just want to prevent any clot formation, and it's very rare that we do see any complications from these implants.
Great. You need to quit. Thank you all for really a fantastic presentation. Really, really wonderful.